Dr. Unni, for including me, and we'll look into the algorithmic approach to pachychoroid disease spectrum. So first to know that the spectrum is ever extending now. Initially started with pachyepitheliopathy, CSC, pachyneovasculopathy, and PCV. Now two new entities, peripapillary pachy syndrome and focal choroidal excavation, has been added to this spectrum of diseases. So common to all this, the imaging features are reduced fundus tessellation and a thick choroid, usually more than 400 microns in thickness, and you have this dilated outer choroidal veins or pachy vessels with compression of the overlying choriocapillaries. And on ICG early phase, you see this early delayed filling of the choroid and the dilated outer choroidal veins or pachy vessels. And in the mid phase of ICG angiography, these areas of choroidal vascular hyperpermeability is seen. So these are the imaging features that is common to all this disease. So now moving to the specific entities, pachyepitheliopathy, which is non-specific RPE changes with or without pigment epithelial detachment, and considered to be a forme fruste of CSR, and has been seen more commonly in the fellow eyes with CSR. So in this, you see best appreciated on the fundus autofluorescence, these RPE disturbances overlying a hyperpermeable choroid on ICG, and then you see the thick choroid with pachychoroid features which we just discussed now. This entity just need to be observed and doesn't have subretinal fluid, but you can see the features like pachydrusen and drusen-like deposits and RP undulations. And this pachydrusen is different from the regular drusen. They are larger, more than 125 microns in size, and scattered all across the posterior pole, unlike the dry AMD where you have the soft drusen which is accumulated at the foveal center. So these are features of pachyepitheliopathy and needs only observation. Moving to the next entity, that is CSC, is generally a self-limiting disease. As you know, you have a serous macular detachment with a point leak overlying a thick hyperpermeable choroid. So we have the more difficult variants of this disease, like fibrinous variant of CSC or bullous variant of CSC with exudative retinal detachment. And this fibrin is usually appreciated by the presence of hyperreflective materials in the neurosensory detachment with or without leaking pigment epithelial detachments. And you see in chronic CSC, we have features of diffuse RP disease and leak, like the diffuse RP epitheliopathy. And chronic CSC on OCT shows these features of intraretinal cystoid spaces, for outer retinal photoreceptor elongation, and double layer sign and PED. And this choroidal thickening that we were talking about may be a diffuse or a focal choroidal thickening, which is best example is a peripapillary pachy syndrome, where you have a nasal macular choroidal thickening with nasal macular intraretinal and subretinal fluid. So for example, this is usually seen in older people with bilateral disease, and you can see the peripapillary intraretinal fluid on either side of the optic disc here. So it is very important to look at the autofluorescent imaging to see the peripapillary RP mottling, peripapillary pachy vessels, and choroidal vascular hyperpermeability on ICG, giving the diagnosis of peripapillary pachychoroid syndrome. Now coming to the management, usually it's a self-limiting disease. We observe up to 2 to 3 months for the resolution, and if it persists beyond that, or if it recurs in eyes with visual deficits, or if the other eye has a permanent visual deficit because of the CSC, or chronicity signs developing like the intraretinal cystic changes and RP changes, or patient needs an occupational other needs for early visual rehabilitation. So the simplest treatment, as you know, is focal laser. It hastens recovery, but it doesn't change the recurrences or the disease in the long term. It is done by doing this basically for extrafoveal point leaks as these with 2 to 3 mild intensity grade 1 to 2 burns given to that area. It hastens recovery, but this doesn't change the disease prognosis as such. So now this is only for extrafoveal leaks. Now for juxtafoveal and subfoveal point leaks, you cannot do this conventional laser photocoagulation, but you need to go for a micropulse laser, subthreshold micropulse laser. Yellow laser is preferred, where the short pulses of laser doesn't damage the RP, but it stimulates the RP. So various studies have shown that for subfoveal and juxtafoveal leaks, these micropulse laser is very effective, but the problem is currently there is no consensus on the parameters, uniform treatment parameters used, and it has to be based on threshold test burn and has to be it has to be titrated to 50% of the threshold burn now. And coming to the next entity for managing CSC, PDT is the gold standard for chronic CSR, where it causes the long-term vascular, choroidal vascular remodeling, and it alters the disease progress once and for all. And single sitting of treatment in chronic CSC, half dose or half fluence have shown equal efficacy in this disease. And we also have shown that similar to the Western, we have 90% resolution in really chronic cases, more than 4 to 6 months of diffuse RPE disease. So, for example, this case with a large subfoveal PED and subretinal fluid in both the eyes of this patient, and angio shows a diffuse RP epitheliopathy leaking pigment epithelial detachments, and this is a chronic case. After the treatment, not only the fluid disappears, but the subfoveal PED also has resolved in 3 months' time. So this is the gold standard for chronic CSR. So now another variant is bullous CSC. For example, it presents with exudative retinal detachment. This particular patient was initially misdiagnosed as uveal effusion syndrome and treated with steroids and vortex vein decompression. When I saw, patient had a reticulolendicular touch. It was so bullous RD. So, and macula off, we had to go for a vitrectomy and endo drainage and settle the retina, and under silicone oil attach retina and then do a fluorescein angiography. And then it shows that on fluorescein angiography, it's a diffuse RP epitheliopathy and choroidal vascular hyperpermeability, giving the diagnosis of a chronic CSR in one eye, and you have a bullous exudative RD in the other eye. So this patient under oil, when you do the angio, it shows this extrafoveal diffuse leak for which the laser was done, a grid kind of laser was done, and then patient goes in for remission and attached retina and silicone oil removal is done for this patient. So we have to tackle such cases with the bullous RD, sometimes surgically as a rare entity, but still you may an extreme case to be treated in CSC spectrum. And when we see such cases with cystoid macular degeneration, this is a late phase and of the disease, and you have a poor visual recovery in such case. Another biomarker is acquired vitiliform lesions or AVL in the chronic CSC setting. This is a poor biomarker, and if you, even with treatment with PDT, you see that this fluid and PED is persisting here. This is another biomarker which suggests that it's a poor prognostic indicator. So pachyneovasculopathy is another entity in pachy spectrum, where we see this occult CNVM or type 1 CNVM with a shallow irregular PED, but in a hyperpermeable thick choroid, and you see this hot spot on ICG angiography. This is a typical pachyneovasculopathy situation, and this is it's a patient referred as chronic CSR with subretinal fluid, but you see the pachychoroid features in the other eye of this patient who has a shallow irregular PED or flat irregular PED overlying pachy vessels. And when you do octa is very sensitive and specific in picking the deep avascular retina, a filamentous network suggesting pachyneovasculopathy in this setting, and it is not a chronic CSC. So it overlies the area of flat or shallow irregular PED, giving a diagnosis of pachyneovasculopathy, not PDT but anti-VEGF therapy with fewer number of injections. So octa is highly sensitive and specific for this indication. Focal choroidal excavation recently added to the spectrum is a sharp choroidal excavation in a normal looking fundus, and it could be a conforming type or a non-conforming type where there is a neurosensory detachment in the area of focal choroidal excavation. The clinical importance of this is it could be associated with PCV or a CNVM, which could usually type 2 CNVM associated with CNV and with FCE, and it needs only very few injections. injections. Unlike AMD or other diseases, this only a few number of injections are sufficient in FC-related CNVM. The last entity we touch upon is a PCV or polypoidal choroidal vasculopathy, which is a serosanguinous maculopathy. You can have serosanguinous PEDs and called as type 1 or aneurysmal type 1, and use ICG is still the gold standard in imaging, where it shows these hyperfluorescent nodules with a halo of hypofluorescence, best appreciated within the first 1 minute. Unlike the other CNVM which causes a plaque lesion in the late phase, it is very important to see these nodular lesions in the first 1 minute. And in the late phase ICG, look for this specific finding, that is the LGH or late geographic hyperfluorescence, which is highly specific in the diagnosis of PCV and not in other types of CNVMs. So now we are moving to non-ICG and non-invasive imaging in diagnosis of PCV with three major criteria. The major criteria being a sharp peaked PED on OCT, sub-RP ring-like structure, and on fast OCT, this complex RP elevation is seen on fast OCT. So this gives around 82% agreement with ICG a diagnosis of PCV. And in a newer report, instead of the complex RP elevation on fast OCT, it is replaced by orange subretinal nodule on color fundus photograph. So many clinics lacks ICG and PDT facility. So we can use the PLANET study criteria, wherein anti-VEGF monotherapy with aflibercept or brolucizumab can be given monthly, and after 3 months only the persistent polypoidal lesions need undergo ICG and photodynamic therapy. So recent RCT showed that even after 3 months, if polypoidal lesions are persisting, it is good enough to extend the loading doses with newer anti-VEGF therapy up to 6 months, which gives almost comparable polyp closure compared to photodynamic therapy. So I summarize that Pachy spectrum ranges from pachyepithelopathy to PCV. CSE is now a choroidal disease with swept source OCT and ICG angiography, and acute CSE up to 3 months is observations, and then focal laser for extrafoveal leaks and micropulse laser for subfoveal juxtafoveal leaks. But both these entities do not alter the disease prognosis or recurrences and do not modify the disease, whereas in chronic CSE and peripapillary Pachy syndrome, half dose PDT is the current norm in treatment, and Pachy neovasculopathy as well as the FC related CNVM, anti-VEGF therapy and OCTA are very important in diagnosing and treating. Anti-VEGF only few injections, and PCV is moving to a non-invasive imaging and monotherapy with newer anti-VEGF like aflibercept or brolucizumab, and persistent polypoidal lesions alone needs ICG and photodynamic therapy in combination. Thank you for your kind listening.
Thank you, George.